A very, I can't say warm good morning. It won't please anyone. We are already sweating a lot. But very happy to see everyone here on the last day. You've made it after the breakfast. It just shows the amount of interest that GAT has generated. And today we will all be diving into GAT, deep dive into every aspect. And I'm very happy to say that we have here a collective experience of probably more than 500 surgeries or even more over the years. And we have pioneers of GAT in India who are here. And I'm so happy to have my speakers, Dr. Mahesh, Dr. Swati, and Dr. Ganesh here. And along with you, I'm looking forward to learn from everyone. Thank you. My first speaker will be Dr. Mahesh. Please.
Good morning, everyone. Thanks for turning up. So, I'll be starting and giving an introduction about GAT and mostly focusing on intraoperative gonioscopy, which is the cornerstone for any MIGS procedures. So, over the course of this presentation, I would be talking about the world of introduction to the world of MIGS, introduction to GAT, and the third eye, intraoperative gonioscopy. So MIGS procedures were described in 2012 as an ab interno approach. They induce minimal trauma to the target tissue and has a faster operating time, modest efficacy. That may be the only drawback. That's why it is indicated in early and moderate kind of glaucomas. High safety profile and rapid recovery with minimal detrimentation to the impact on the quality of life. So this is a flowchart from the American Academy of Glaucoma, and this is the glaucoma surgery armamentarium that we have at present. Apart from the traditional glaucoma surgeries, which are the bleb forming trabeculectomy and the equatorial bleb forming devices, ADI and the AGV and Barweld implant, we have this MIGS procedures which are classified as non-bleb forming and the bleb forming ones. And the non-bleb forming ones target the inflow and the outflow of aqueous, and endocyclophotocoagulation is the one procedure which decreases the inflow. And for the outflow mechanism enhancing procedures, we have stents and the cleaving procedures. So in the implants, we have iStent inject, hydrus implant, and the excising procedures, we have trabectome, Cahuck dual blade goniotomy, 360-degree GAT, and bang procedure. And we would be mostly focusing on GAT. The procedure was developed by Dr. Grover and his team at the Glaucoma Associates of Texas, and it's a non-bleb forming MIGS procedure where the Schlemm's canal is deroofed. It's a conjunctiva sparing ab interno 360-degree trabeculotomy and can be either using illuminated catheter or 50 Prolene suture used. My topic would be mostly on intraoperative gonioscopy, and the further speakers will talk about their experiences on the procedure, the modifications, results, and all that. And as I told before, this is the third eye and forms the cornerstone for any MIGS procedures. And essentially, we will be looking about the perioperative steps, which will include preoperative office-based gonioscopy and angle anatomy, and intraoperative about the head microscope rotation, the gonios lens selection, hand position, and all that. Step one is office-based gonioscopy. And as Winston Churchill said, if he who fails to plan is planning to fail. And why do we need to do office-based gonioscopy? It's for surgical planning. You need to know whether the angle is open or not, whether it has undergone previously trabeculectomy, whether the ostium is there or not, and any localized areas of synechiae, broad-based synechiae, angle neovascularization, all these things needs to be seen. And as much as possible, preoperative gonioscopy is done. It makes you more confident to do intraoperative gonioscopy. And this website, gonioscopy.org by Dr. Albert Wallace, will has an atlas of gonioscopy and all possible angle descriptions that is available. Step 2 is the angle anatomy, and the most important surgical landmark that you need to localize is scleral spur. It is the surgical landmark that differentiate anteriorly, where we do all the canal based surgeries via the trap meshwork, and posteriorly we do all the suprachoroid based surgery via the ciliary body face. About step 3, we'll be talking about the anesthesia. You have the choice of either topical anesthesia or peribulbar or retrobulbar anesthesia. Once you are experienced, you can go into using topical anesthesia, where involuntary eye movements may be there and that you can take care of. But if you are starting, for a novice surgeon, it is not unreasonable to start with a peribulbar or retrobulbar or subtenence anesthesia also. It builds the surgical confidence and avoids potential intraocular complications. A most important step in the step 4 is the head and the microscope rotation. So most often we sit temporally. There are modifications where the surgeons, based on their choice, can sit sometimes supratemporally also, but most often temporal approach is the approach practiced, and we target the nasal angle. And in this, to get the proper view of the angle intraoperatively, the head of the patient has to be turned 30 to 45 degrees away from the surgeon, and the microscope has to be rotated towards the surgeon to the same amount. And at the end point, the eyepiece of the microscope has to be aligned to get a coaxial illumination along the iris plane. And then you start increasing the magnification of the angle and increase the light intensity to view the angle structures. And never attempt to do any MIGS procedure if you are not confident and if you are not able to localize the trap meshwork and the scleral spur. It's a small video about the microscope rotation, where the microscope is tilted 45 degrees towards the operating surgeon, and the final alignment was the oculars alignment to get the coaxial view along the iris plane. And these are some tricks which you can do to your microscope, where you can mark the 0-degree angle and make another mark which will tell you that this is the 45-degree angle, so that every time you don't have to measure, or every time you don't have to fiddle around your microscope. When you go next time, you are going to do a MIGS procedure, you know that this mark, when aligns together, it's my 45 degree. And that measurement in the iOS app, you have this measure app. You can use any app in the Android or Windows, and you can measure that 45 degrees. So this is how it's in the laptop, which is aligned at 45 degrees, and the measure app is giving you this alignment. As compared to cataract surgery, when you're doing this MIGS procedure, since you are sitting away, the microscope is towards you and the patient's head is away from you, the hand distance is more as compared to how you are operating a normal cataract surgery. And while you are doing phacoemulsification or a cataract surgery, you are doing bimanual procedure, where the hands both are working inside the eye, and you have complete exposure access to the entire cornea. But while doing MIGS procedure, your view is confined only to the anterior chamber and the angle, and your hand has to work intraocular and extraocular. Your threading has to be intraocular in the anterior chamber, and your hand holding the lens has to be extraocular. So hand-eye coordination is very important. Coming to step 5, gonio lens selection. It's earlier we were provided with only the Swan Jacob lens with Oak or Ocular company, but now there are a lot of companies providing lenses. They vary in the degree of corneal contact or the field of view and the magnification and the handle length. Most of them are, the handle is contiguous with the gonio lens, except the TVG lens from Oak, which has a free floating lens originating from a separate handle and has a clawed ring to stabilize the lens, and it rotates in X and Z axis. So this is the usual Swan Jacob lens and the Ocular and the Hill lens. All Hill lens comes with right hand, left hand dominant people. For them, the handle is aligned to be friendly. This is a TVG lens, where I said this is from the posterior view. If you can see these, This is the clawed ring, which will help you to stabilize the gonio lens on the globe, and this is your floating lens, which can actually move in X and Z axis. Step 6 is the hand positioning. So for a right dominant person, you have to, for any right or left dominant person, you have to hold the lens in the non-dominant hand so that intraocular movements are in your dominant hand, and placing the place your hand on the forehead or cheek based upon the laterality. When I say that, so this is for a right dominant person in the right eye. So he will be sitting towards the temporal side, and the right dominant hand, the left hand will be holding the gonio lens, and the hand will be resting on the forehead of the patient. For the same right dominant person, when he is doing for the left eye, he will be sitting temporally, and the hand holding the gonio lens will be resting on the malar prominence or the cheek. Yeah, and this was the previously I discussed phaco, where you have the bimanual intraocular surgery, and the angle procedures are extra and intraocular simultaneous manipulation. There are various ways to identify the trap meshwork intraocularly. Based on the pigmentation, moderate to heavy pigmentation obviously provides a natural visual guide. The areas of greater pigment indicate closer proximity to the CC and the blood. By doing a provocative gonioscopy, you can force the reflux of blood into the Schlemm's canal and identify that. Or if you are doing the procedure under GA, you can ask the anesthetist to induce a hypotony by relative hypotony, and that will again induce reflux of blood into the Schlemm's canal with IOP drop. And this is also described where you can stain the trap meshwork if it is non-pigmented. If you feel that it's not pigmented enough, you can stain and see, and the trypan blue is used to train the trap meshwork. This is how intraoperative angle visualization looks like. I think the further speakers, when they talk about the surgical procedures, we'll have a proper videos of that. The take clinic message from my talk would be gonioscopy plays a very important role in the perioperative preparation of MIGS procedures, not just GAT. And practice makes a man perfect. So every single time you do a office-based gonioscopy, and what we advocate usually is when you're done with your usual cataract surgery, if you have your gonioscopes with you, you can just put it over the cornea and visualize the angle. Especially after doing a cataract surgery, the angles nicely opens up. You can have a good view of that. And even if you want to take your next step forward, you can go take your Sinskey hook, go to the angle and just touch the Sinskey to the angle and see whether you are actually reaching the trap meshwork or not. Thank you. While Dr. Ganesh sets up his PPT, we can take some questions if there is any.
This hall is not too big. We can talk from the chairs.
HDM
What gonio lens?
नहीं वो चाहिए अडाप्टर चाहिए Hill ocular lens Hill ocular lens Hill ocular
The eye prism SX, especially with the reusable
आगे वाले में आगे वाले
they can purchase that, which is available for I think 6,500, 7,000 rupees. And you can video it and you can use it. It's from the Globus Eye Scan Group, the eye prism SX.
Yeah, so for beginners who want to test out, if you want to do the GAT or any angle based surgery, you can actually get that lens for less than 7,000. And it is supposed to be disposable, but you use video, and then I know people who have used one lens for more than 3 years. Take care of the lens. Taking care means that you don't wipe it at all. Just wash it, shake it off, air dry it, and then keep it in a case which is not metallic.
Thank you. At the outset, I'd like to thank Dr. Siddharth and the Chairman AIS Scientific Committee for providing me this opportunity to speak to you on GAT, patient selection, and my experience. So, As Dr. Mahesh has mentioned, there are numerous ways where you could practice intraoperative gonioscopy. Of course, you have to do gonioscopy in the outpatient department, that's a given. But in the operating room, you should practice intraoperative. There are a lot of opportunities to us, especially when you remove angle foreign body, when you want to assess scleral wound. For example, the image in the lower portion, you have a fish mouthing of the SICS section. So you want to see what is happening inside. You do that in the operating room also, as well as in the OPD. When you want to repair a cyclodialysis cleft, when you implant a glaucoma drainage device in the sulcus, you can see where it is being fit correctly. It's too far extended or before, you could use intraoperative gonioscopy. Goniocycling, like you can even use a Sussman lens in the OR. If you have ETA to it and you're prepared for it, you can use the Sussman lens to look at all the angles. And patient positioning already been done. I think Dr. Swati may also mention it's important that we consider the reverse Trendelenburg position to reduce the reflux of heme into the eye. And now we have all the equipment. We don't have any shortage of equipment. That's why we are able to do much better now. We have good quality forceps. So micro forceps are very important. You could also use the micro rhexis forceps. I'm going to show you a video where we use a micro rhexis forceps to push the suture into the, so you don't have to run to the retina department, borrow the micro forceps and start doing the procedure. Or if you have one only with you and it's been used, you can use your micro rhexis forceps to do the, make sure the tips oppose very well. If the tips don't oppose and there's a gap, for example, I'm struggling to catch hold of the suture, and when I take out the forceps outside, when I clip this, the tips are not opposing. Can you see that? So that's a defect. So you introduce it into the eye, then you realize the tips are not opposing. So make sure the equipment is good. And the gonio lens, as we already mentioned, these are the all n number of gonio lenses which are we have now. The Vogue original one was ergonomically quite unsatisfactory, but it still does the job. The original Vogue, the one before the TVG. And Prism S, Prism S is the one from Glaukos. It gives a very nice view. This is how it looks. And this is the Ocular Hill gonio lens. Swan Jacob does the work very well. Main advantage of Swan Jacob is you can post multiple patients because it's autoclavable. These are not autoclavable. Swan Jacob you can autoclave and use for multiple surgeries. And sutures, we use the 5060 Prolete. We get it from Aurolab, and Dr. Swati and Dr. Siddharth, they prepare it in the OR, so that's a big advantage. And viscoelastic sodium hyaluronate is very important. I always leave sodium hyaluronate in the eye, almost 30, 40, 50% fill as much as possible. And table height, positioning, and surgery time is always dicey. Sometimes it takes 5 minutes, sometimes it takes 1 hour. So at the beginning, be prepared to have a lot of perseverance. And then as you get by, you can do it a little faster. And this is a nice article from Dr. Vinay Gupta's group. He had a, I think, free paper competition with Dr. Siddharth, where he showed the types of angles, Jonal angles in the free paper section. So normal appearing angle is the best angle to operate in. So that's the one to go to. Avoid featureless angles. If you see a featureless angle, those don't do so well. There are actually some sort of dysgenesis is there. High iris insertion and prominent iris process also do pretty well. So that's something which I teach my fellows there. And we always try to pick up patients who have only this type of normal angle anatomy. Avoid featureless angles. There's a tissue is totally abnormal. You may never get into the Schramm's canal. You may pass the suture, it may come out anywhere. So it's very, very tricky. And this is an example of a featureless angle. You don't see any demarcation except the ciliary body band slightly, but otherwise it looks non-pigmented, slightly pale. And this is an angle with slightly high iris insertion. So you could see that it's slightly high iris insertion, but it still will tear the trabeculum meshwork, and you can perform a very good procedure. This is again a high iris insertion. Iris processes are extensive, and this is somewhere you don't see the exact features very clearly. So be very careful with such angles. The ideal patient would be a POAG patient with cataract. So you could do the cataract first or do the cataract later. Normal tension glaucoma with cataract also is okay. Even patients with glaucomatous optic atrophy, near total glaucomatous optic atrophy, The idea is that you can reduce the intraocular pressure transiently, and then you can plan for your subsequent surgery later. So the prognosis is really very poor, and because of that, because it's a closed globe procedure, there's not any prolonged hypotony. These eyes do pretty well compared to a trab done in these eyes. Patients on minimal duration of medication. So recently diagnosed patients on many medications. There are other the most gratifying patients are patients who have got trab in the other eye. So if you do a GAT in this eye, it works like magic, and they are the most gratifying patients. Avoid patients with a high expectation. So never tout it as something like a sutureless surgery. We never tell them that it's going to be we never use the word sutureless. So we always say it's going to be a pressure reducing surgery. So in case you have to convert to a trabeculotomy, which is again the same thing, you could just convert with a trabeculotomy. Patients with abnormal angle, hamartomas, for example, Sturge-Weber syndrome, avoid such patients. They are not ideal candidates for this procedure. Nevus of aorta is another one condition. So this is just to show you a video how you struggle during the procedure. So the suture's gone in, and make sure that once the suture has been placed inside, then I give the nick. So there are three places where you can cut the trabecular meshwork. You can cut it on the higher level, the mid level of the trabecular meshwork, or the lower level of the trabecular meshwork. If you cut the lower level, very easily the suture can go. So this is the bubble trouble. So once you inject the viscoelastic, make sure you inject viscoelastic outside and then go inside and inject viscoelastic. So avoid that. And then you catch hold of the forceps and introduce into the trabecular meshwork. This should be a little easy, but there will be a little bit of struggle. As Dr. Mahesh has mentioned, your arms are extended, so you have to reach out and do the procedure. So it's technically a little difficult. You have to get the hang of it. And once you have introduced the suture, you should have some resistance to movement. If you don't have the resistance to movement, so I'm introducing it, it's going, and I've introduced a significant proportion of it. But as I'm introducing, the suture has actually has cut the trabecular meshwork, and in the right side, on the corner, if you see, the suture will be visible in the gonio lens. So it's actually has cut and come inside. So these are the early learning problems which you will have. It depends sometimes I feel that it's mainly because of the umbrella tip. You can see the suture there. Just past. So it's mainly because of umbrella. If the umbrella is kinked at an angle, then it can tear inside. So make sure the umbrella is correctly perpendicular to the suture stem. Then after this, I'm going in the reverse direction in the same patient. And I find that it's gone into the sulcus. It's going in very smoothly. It's made a passage and it's gone into the sulcus. It's not in the anterior chamber, so it's been, and the pushing, I don't feel any resistance. So because of that, I come out again. I clean the eye, wash the eye, and then I do it anti-clockwise again. So you see the trick here is it's entering into the angle straight. It's not following the curve of the globe. So the important thing is it should follow the curve of the globe. If it's not following curve of the globe and it's tangential, that means it's in the false passage. The same patient again, we bring it out and then introduce it slightly higher up in the cut edge of the angle, trabecular meshwork. It pops out, then I go a little bit behind, further behind, and follow the curve of the globe and then introduce it. And once you push it, you need about 19 to 24 pushes. So that's people recommend not to use the stroke, but rather than to, maybe make it a kink. But sometimes the kink we are not able to see or visualize. So I rather prefer to use a number of strokes. about 19 to 23, 24 strokes are required. So the same patient, we went in anti-clockwise, wasn't happening. We went in clockwise, that wasn't happening. Then we came back and again went anti-clockwise, that worked. So the important thing is that's why it takes 50 minutes. So you should not lose perseverance when you do the procedure. So this is another patient who came to us about after 1 year of the other eye. So this is how you initiate the surgery. Sorry, just a second. How you initiate the surgery is, so the patients I'm showing you are phakic eyes. Most of them are juvenile glaucomas or early POAGs. Once you introduce the suture through the side port, I always try to place the side port supranasally or infranasally. And these Gonius lenses required some sort of coupling device. So you use the OVD, and then when you tilt, use the focus and fine focus to visualize the angle. So you should have an unfast view. So the trabeculae meshwork should hit your eye directly. So it's like looking at a mirror right in front of you. It should have a good view and give a nick. And because of you could see the chemosis, the subtenance block was so heavy. So you have and the suture just come out. So I have to introduce the suture again. When you lifted the lens, the suture came out. So be very careful. And then again, remember the bubble trouble that always causes a problem. And once you have identified, blood is actually good, mainly because it helps you to identify where the incision has to be placed, blood in the Schramm's canal. Sorry. Oops, I think the view isn't very good. So this, because of the peribulbar block, the subtenance block, the chemosis was so severe that the patient had a severe regurgitation of blood from the Schramm's canal. That's better. Okay. And you will have to apply, come out, put viscoelastic, go back in, do the procedure, come out again, put viscoelastic. That has to happen constantly. Sometimes the bleeding is so much it covers the interface between the lens and the cornea. So that also we have to keep cleaning the lens at the bottom. And then once you are through, you pull the suture and do the trabeculotomy. And once that is done, it's important to wash, and I'll show you. Then come back to the original position, wash with the IA or Simcoe, whatever you're familiar with. And finally, I always use almost 30-40% fill of viscoelastic in the eye. Sometimes even up to 60% I would like to leave viscoelastic. When you are taking out the suture, make sure that it's done very slowly and you don't nick the anterior capsule. That's another thing which you have to remember when you do so this is how you fill the chamber. So we use sodium carbonate only, the normal one 1.4%, and leave almost 60% fill into the anterior chamber. And this is the same patient post-op day 1. You could see there is bleeding in the eye, blood clots, and you can see the vision is 6.6. The intraocular pressure is 10 millimeters of mercury, and chamber is filled with viscera. You can see the reacting pupil very nicely. So patients do very well. They don't have any sutures. They feel very gratifying. This lady actually came to us after getting the other eye done for 1 year after that. So she wanted to see, she has a medical background, not medical, but science background. She wanted to see the response of the procedure after 1 year. So that's on the left side is the right eye, which we had done 1 year back, and this is the freshly recently operated eye. So she wanted to see what is the result, and then she wanted to undergo the other. So both the eyes are now off medication. So you could also This is another patient whom we had operated. She is high myope, minus 12 D sphere, and she had a high FEMA on the first day, but she was reading well. We tapered the steroids, and pilocarpine we used for 2% just for because the intraocular pressure was hovering around 17 to 20 millimeters of mercury. So this is the results of our brief publication, which we had short publication. We had juvenile glaucomas, secondary open angle, pigment dispersion. So we operated baseline IOPs was quite high, 40, 25, 44, 24, 34. They all multiple medications. At the end of the only 2 patients did not do well. That's a nevus of and viral keratitis patient with secondary glaucomas. But other patients we were able to bring down to good low intraocular pressure levels at 1 year follow-up. So intraoperative complications, poor view of the angle structures, mainly because of positioning. So not accessing the Schlemm's canals because the gonioscopy is actually, maybe that's not the correct patient we are trying to do the procedure in. Bleeding will come, how we can control the bleeding. Iris prolapse can occur, especially if you use a 2.8 millimeter incision instead of a 2.2. So be very careful. Some people try to do through a side port. That's even a better idea. Lens touch, especially when you're manipulating the suture or introducing the instrument into the eye. Cyclodialysis can be caused, and iridodialysis can also be caused. Some literature is there in which you can even cause a Descemet's membrane detachment. So positioning of the patient is very important. So make sure that the positioning, sometimes after 10-15 surgery we become very lax. Okay, why 35 degrees of tilt? Why can't we do it in 20 degrees? Why to tilt so much? And also you start doing it like 30 degrees, 35 instead of 30, 35. Then you say, okay, even if 35 is okay, we can do it in 25 degrees. So that shouldn't be, it should be more. So if you've done the first cases, everything goes through very nicely and you're not getting the hang of it next time, that means something's wrong somewhere. So that laxity shouldn't come. It should be always more, but not less. So tilt of the microscope and tilt of the head should be more than 35. So whenever you have a problem, move the patient's head more away from you. And this is what you have to continuously teach your junior colleagues also. If they don't tilt their head sufficiently, they will not be able to see anything. And if you're not able to do it, reconsider diagnosis there itself. Don't think that you could push the suture anywhere. Reconsider and be very careful of featureless angle. Not cannulating, I showed you, it wasn't in the same video. You are not inserting it into the Schlemm's canal properly. Always have a plan B. So the plan B for us is always an external trabeculotomy. So we always have an external trabeculotomy which we prefer to do. Angle anatomy, I would like to re-emphasize this because I find this the most crucial aspect. So OPD, in the OPD, gonioscopy has to be done very, very well. So before buying your surgical gonio lens, if you don't have a gonioscope in the OPD, please buy that first. So bleeding is important. You can have excessive bleeding. So keep the eye pressurized always. So always keep the eyes pressurized. Because of this, you can even operate advanced glaucomas, in which if you do a trap, the vision will drop to 5/60, 3/60. But if you do this, the vision remains better than 6/12. And when you keep the eyes pressurized, it helps to open up the Schlemm's canal. Schlemm's canal is like a rubber tube in the tire which has got punctured. So it just collapses. You introduce something into that, it will go and kink somewhere. So Schlemm's canal, if it has to be cannulated, my afternoon talk is on canaloplasty. I do the same procedure externally. So if the suture doesn't go, that means there's somewhere the Schlemm's canal has kinked. So inflate the eye properly. The Schlemm's canal, the inner wall and the outer wall have a tendency to collapse and stick to each other. So if the outer wall is collapsed, soft, the eyeball is soft, the outer wall and inner wall touch each other. Inner wall is more flexible, outer wall is stiff, but still the inner wall will touch the outer wall will touch the inner wall, and you cannot pass the suture. It can kink through and cheese wire. So if your suture is in antechamber, you have been doing the procedure in an eye which is very soft. Smaller incision, I already mentioned. Iris prolapse, to avoid that, use a 2.2 incision or even smaller. Move towards the nasal angle so that the introduction of the suture into the trabeculum Schlemm's canal is easy, and avoid large volume block. Lens touch hasn't happened to me so far, thankfully, touch wood. It's a rare complication. You can have a peripheral touch. Careful when the suture is brought out of the section. So this sort of, sometimes you have a whip sort of an effect. When the suture comes out, it comes out in a whip fashion. So be very careful with that. So when you bring out the suture, be very careful, take it out. If you're operating a phakic eye, take it out around over the iris and around. Cyclodialysis, you can have profound hypotony. So if you do a good GAT, you'll have a IOP of between 10 and 14. But if you are getting anything less than 9, search for the cyclodialysis cleft. 8 and so I had a patient who had a very POAG but very high lens vault. So I didn't think of it at that time. So it retrospectively hit me when he came for the evaluation. Then I did a scan. I saw his lens thickness was almost 4.9. So I was operating on him as though I was operating on a POAG patient, and it didn't occur to me that a POAG patient will have a high lens vault. So I was going over the lens and operating, and I caused a cyclodialysis cleft. And because of that, he was having IOP of 6 and 5. Then I saw the cleft. Then I said, okay, he developed cataract, thankfully. So I did the cataract and the cyclodialysis cleft together, direct cyclopexy. So that's how, things happen. So assessing the anterior chamber, we are looking at equipment which can do assessment of the anterior chamber sections. Very nice. So we need the lens wall data, lens thickness data, even before practicing these procedures. Small iridectomy you can always leave, and that's the small size which have just like iridectomy. There's nothing more than that. You don't have to really go after them. You just manage conservatively. Post-operative complications, so far if the case selection is good, you don't have raised IOP. If the case selection is not so good, then you'll definitely have a raised IOP. Shallow chambers can occur, especially if you don't fill the eye with OVD. So what happens? You have removed the resistance to the trabecular meshwork. You are pumping the patient with anti-glaucoma medicine till day 1, even till, so the washout effect hasn't happened. Whatever has to be retained in the eye cannot be retained because you open the trab meshwork, so everything flows out. So what happens to the eye? What happens to the eye is the ciliary body cannot produce aqueous at the rate at which you expect it to. So everything moves forward, and there is a supraciliary effusion. Some people have reported that. So if you leave the eyeball soft without viscoelastic, you can have this. We had 2 patients have this, and then it became something. It will present something like an acute angle closure glaucoma. So you'll get into a misdiagnosis, whether do a PI, not do a PI, and all that. So it's very, very careful. You have to be careful. Look at the physiology of the eye and then take a decision. You are giving him 4 or 5 anti-glaucoma medicine till yesterday. You open the trabecular meshwork today, and aqueous is not getting produced. Aqueous is flowing out at rapid rate. And what happens to the chamber? So you have to think about it. High fever can occur, so make sure you avoid taking initial patients who are hypertensive, who are an so always measure the blood pressure, make sure that blood pressure is under control. And also post-operative PAS formation, you can have the patient, myope patient whom we had the other eye when we had extensive PAS formation. They present with raised IOP. So immediately go back in, remove the PAS, they start functioning very well. PAS is actually a good sign. So if you have PAS, it's a good sign that flow is good, number 1. The excessive flow is being arrested by PAS. If you have extensive PAS, that means the chamber has not been maintained well. So you have to go back and they will fail. So you have to go back and release those PAS. 1 or 2 areas of PAS is good. They don't extend, they don't go beyond that particular area. Late bleeding can occur, so be very careful when you are operating patients who are hypertensive, diabetic, and also a very high chance of going in for a cardiac event. So if they are put on clopidogrel, they'll be in a soup. If you're driving and you have bleeding, you're going to crash somewhere. The patients are going to crash somewhere. And failed GAT, what are you going to do for failed GAT? The next option is always usually a trab, but be very careful when you do trab in failed GAT eyes, you can get profound hypotony. So don't use mitomycin C, apply tight sutures, release the sutures late, because GAT works. It's not that it's not working optimally. It's not working to the level which you expect it to work, but actually it was working because you remove the trabecular meshwork. So you can get a profound hypotony. So I'll stop here. Any other questions? I think after this session we can take. Thank you.
Thank you, Dr. Ganesh, for a wonderful talk and amazing tips. I will now request Dr. Swati to please share her experience with the eager crowd.
Good morning, everyone. Thank you, Siddharth. Thank you, AIOC, for giving me this opportunity. So, I'll be talking about woos of the GAT, learning curve, and how to beat it. Most of my things have been covered in part by Dr. Ganesh, so it will be an overlap. So, as Sir said, prerequisites for any mix are sound anatomy, sound knowledge of angle anatomy, suitable surgical gonio lenses in your armamentarium, direct mastery over direct and indirect gonioscopy, because you need because it is not the thing which we practice day in and day out. So we have to take a time out at the end of the OT, do some intra gonioscopy on our FICO cases. Most important, you should have a tiltable microscope. If you don't have a tiltable microscope, it is very difficult. Also, you should have an adjustable table, so that the patient height, the table height can be adjusted. And also, to have the head end of the table elevated, you should have the tiltable table also. So microscope also should be tiltable, table also should be tiltable, and also you should have a mastery of the microscope foot pedal, because both the hands will be engaged in doing, one will be holding the lens, another one will be feeding the suture, like that. So ambidexterity, we all are ambidextrous now, and we should have lots of patience. As Mahesh said, practice is very, very important, and patience is also very important. Prerequisites for suture GAT are low temperature cautery, and if you don't have a low temperature cautery, you can have a heat cautery or the ball cautery, and you can just bring it closer to the cut end of the suture. So there is no role of this needle. Just cut off the needle of the 50 Prolene suture. You can use it, throw it away, and then just the suture. And one suture you can cut into many pieces of around 4.5 centimeter each, and then you can keep using it. The other one suture use in one case and then discard, another one keep cutting it and then keep it ready, mushroom it, and then keep for the other cases. And if you don't have ball cautery also, you can heat up a spatula, cyclodialysis spatula. This is what I learned from Siddharth. So you can just heat the spatula, you can bring the suture closer to the spatula, and then it will become a mushroom. So what is the logic behind making mushrooming the tip is because it is a very sharp suture. It can create a false passage if it is not smoothened out, the tip is not smoothened out. So that is why we have to make the tip smooth. Otherwise it will go in any plane wherever it wants. So low temperature cautery, if there, very good. Not, then heated spatula and heat cautery. Helon GV, if you don't have, you can have Orogel, and you can have BioHylo, which is from Biotech company. So the point is, it should be 14 milligram per ml or 18 milligram per ml. It should be cohesive. Swan Jacob Gonio Prism, as Mahesh made it clear in his presentation, you can also have Eye Prism S, Eye Prism SX, Eye Prism OA, or Katina lens. They all have, and depending upon your use, you are a right-handed surgeon or a left-handed surgeon, you can buy the lens which fits in your hand. So it is a left-handed also, right-handed also. 50 Prolene suture. Some people use 60 Prolene also. So suppose if you feel that the trabecular meshwork of a patient is not of a normal width, you can go ahead with 60 Prolene also, like in children. Or if you feel that it is a broad trabecular meshwork, you can go with 50 Prolene suture. Then MVR blade, 25 gauge, you can borrow it from your retina people, or if you are in a private practice, you can just keep on ETOing it and you use it. MSD forceps, which should be serrated, they should have serrations at the end, and McPherson's forceps, which is freely available. Patient selection, as Ganesh sir said, that this anatomy, where you can see the Swalby's line, the pigmented trabecular meshwork, the scleral spur, and the ciliary body band. So if you can see the scleral spur nicely in the nasal angle, you can go ahead with any angle surgery. But if an angle is like this, which you can see on the right hand side, it has got lots of pigment dispersed, pigments over the scleral spur also, and Schwalbe's line also is pigmented. So you intraoperatively you might get confused, okay, where should I give the nick? And if you go and make a nick in the ciliary body band, then you will have a cyclodialysis cleft. So before you start, Mahesh has covered intraop gonioscopy, patient positioning. So how do you position the patient? I was supposed to have some photographs here, but they are not there. Anyways, this is intraop gonioscopy. Here on the right hand side, you can see I use HPMC. HPMC doesn't stay on the cornea, it just flows away. So don't use HPMC. Keep Orogel at your disposal. Keep 2 for one case because it will be just 2.5 ml, and before you know it will get finished. So just keep 2 on table. So this is the angle which you want to see. Start with a lower magnification, and once you are getting the view, then increase the magnification. You can manipulate the patient's head if you feel that no, I'm not getting the end fast view. So as you can see here, this is the view which we want. So patient positioning, correct positioning, I have tilted. I always do my mixed procedures with the head end of the table elevated. So it will be in a reverse Trendelenburg position so that the blood reflex from the Schlemm's canal is less. Then turn the patient's head away from you, tilt the microscope towards you. So I'll be showing you some intraop complications. So once you give a nick in the trabecular meshwork, you will have reflux from the collector channels. Anyways, after doing phaco, if you are doing GAD, it will be filled with blood because of the hypotony which we induce during the phaco. So be prepared for that you will face some blood. So pre-fill the anterior chamber with Helon GV or Orogel. Keep the head above the heart and use high viscosity OVD. What if you have a false passage? To avoid false passage, you can use intracameral pilocarpine to constrict the pupil. Proper understanding of the angle structure is important, and you should blunt the tip into a little mushroom, not the one which you can see on the right hand side, which is a very large mushroom. So if you have a very huge mushroom which is out of proportion to the trabecular meshwork which we are going to feed it into, then definitely the suture is going to take some other pathway. And limited initial goniotomy, the 1 clock hour is enough. You should have some trabecular meshwork on both the sides. Suppose your anti-clockwise is not proceeding, then you have to feed it in the clockwise direction. So you should be seeing your suture going behind the trabecular meshwork. So that is why initial goniotomy of 1 clock hour is enough. And also you should confirm the suture pressure in the Schlemm's canal by doing an indirect gonioscopy. So you can see, so this is the suture, this is the blue color suture which you can see, this is behind the trabecular meshwork. So this blue color is also helpful in making you see where your suture is. So here you can see that till this point it has reached and this point is still left, this part. So you are assured that okay, I am not in any other plane, I am in the Schlemm's canal only. But if your suture doesn't advance any further and you are stuck up in spite of putting it inside, so how do you know how much suture do you need? Pre-measure the suture. So just make a loop of the suture around the limbus and just make a kink or mark it by making a small nick on the suture, so that you know this much suture roughly I'll be needing. And if that kink appears inside and still your suture has not appeared from the opposite side, then you are in trouble, that maybe it has taken some other pathway. So pre-measure your suture, confirm the suture in the Schlemm's canal, and you can do a twin side GAT or a clockwise GAT. So because I'm a right-handed person, it will be easier for me to feed it in a forehand fashion. But if somebody is a left-handed surgeon, they will be feeling better in putting it in a clockwise direction. So depending upon which handed person you are, you can start your surgery. And resistance is normally felt at 180 degrees when the suture has to take a turn towards the opposite side. So it's a good sign, but sometimes you can't just keep on pushing it and it doesn't appear. So just abort it and then feed it in the other direction. As Ganesh sir said, you might have shallowing of anterior chamber while doing, because you are not aware your left hand is keep on pressing because you are in so much of stress, because you want the suture to go in the proper position, and unknowingly our left hand presses. So we have to fill the eye and nicely with Orogel and then gently place your hand on the eye. And you can support your hand which is holding the lens on the forehead or on the cheek as per the laterality of the eye. Post-operative pulse, leaving Orogel in AC 30% or 40% fill, which acts as a tamponade. Do a very good pre-op counseling of the patient and tell him or her that there can be bleeding in the eye, but it is self-resolving. It will be resolving in a week's time, and also you have to sleep on the side of surgery for at least 1 week and with head elevation. So whatever hyphema occurs, it will trickle onto the temporal side, and the nasal side will be free for filtration. Post-operative IOP spike can be dealt with by using alpha agonists or beta blockers, and we use steroids and antibiotics. So it depends upon your center. If your bleeding is not too much, you can quickly switch over to NSAIDs, but if you have a lot of heme, then you have to continue steroids for a longer period of time. If time permits, can I show this video? So I'm blunting this is a low temperature cautery. So this is the one on the right hand side, which is a very big one. So I was not knowing how much to make it flange. So I used to make big flanges initially, and once my suture came out through the OP, so it gave me a heart attack on table. Then what have I done? And always all your incisions should be clear corneal, so that these limbal vessels do not trouble in the doesn't trickle under the corneal lens. Your view is unhampered throughout the surgery. And most importantly, this side put which I have made, your angulation towards should be the nasal angle. These are very small dips. While doing, if we can keep all these things together, we can have a good surgery. This is the relaunched Orogel I put on the cornea, which stays there. What prism I am using is eye prism OA. OA is open access. It is given to me by Globos. So this is the area where I am always making a small 1 clock hour goniotomy. So you can see, I can see my radicular mesh on either side of my goniotomy. So if my anti-clockwise doesn't work, I can go clockwise. These are empty first steps. And see, your suture is going behind the radicular meshwork. So you are in safe hands. Your suture is in safe hands, and okay, fine, I am in the correct position. But still, if I am having any doubts, I can have goniooscopy on table. This is the indirect goniooscopy. I can see the suture in the right canal, and the steroid spur is seen. Then now I will rotate it. This is a single mirror gonio lens, which we can keep in our this half part is done and half part is not done, and it is in opposite lens. So you have to make the patient aligned again coaxial, put the lens, see, confirm in the opposite, like it will be in the opposite direction, and then again tilt the patient's head. And then now I am having resistance, as you can see, because my suture is taking a turn from the 180 degrees. The angulation of your suture should be circumferential, as Ganesh sir has shown. We should not be back on towards, like it should not be perpendicular, because if you are perpendicular, then it will push your suture into the suprachoroidal space. Now you can see the suture has appeared from the other side. It really feels very nice when you get the suture coming from the opposite side. Then hold the suture on top of the suture which you have used before, bring it to the center. That means that you are creating a goniotomy in that part. Then using your first scissors, you will take it out, so that the inner wall will be cut 360 degrees. Then you can proceed with your fake home. So the take-home messages is moderate open angle glaucoma cases are the initial ones you should start with. They should be widely open angles. Pre-op counseling should be done. practice intraop gonioscopy on routine phaco cases, do a limited initial goniotomy, feed the suture in the Schlemm's canal, don't push it, keep the head above the heart, use liberal OVD, use indirect gonio lens to confirm the suture position, and be patient and perseverant. Thank you.
Thank you, Dr. Swati. I would recommend that you must have learnt a lot from her. But once you start doing, if you're not already doing, just come back and listen to the talk again. You will then know what more to pick up. So when I had started GAT, I thought I'm doing everything perfectly and there is nothing more that I can learn from anyone. What can someone teach me? But then the moment every person that I listened to, there was something new that I picked up. So once you start, you will know what to pick up from that garden of wonderful fruits that. Okay, लगा दिया ये. हाँ. Garden of wonderful fruits that take care of. For this size of hall, I don't need a mic actually. क्या हुआ? नहीं हो रहा है. आपका word आपने अभी. हाँ सर इसमें. This just shows that Steve Jobs and Bill Gates are not very good friends. Right, so you have seen many wonderful videos, and I will just show a few things which we thought of right in the beginning and were innovations. Some of these you have already seen. The simplest of the things is the ability to make these sutures. Now, when we started GAT, we had these sutures available, but then the pandemic struck. And there was a time when you didn't have these sutures. And this is something that one of our nurses thought of and then we worked upon. You just need to heat a cyclodialysis spatula or an iris repositor with any heat source that you have. It can even be a candle, cigarette lighter. So we have one in the OR now, and everybody who comes in keeps asking, why do you have this in the OR? Who smokes inside the OR? So you can just do it. What is very important, and we learned now, that you make one side of the tape smaller and the other side a little bigger. So using a 6-0 Prolene, if you do that, the angles are all different, eyes are all different, and so is the Schlemm's canal. Sometimes with the same size of the umbrella tape, you'll not be able to go through, and sometimes it starts passing in very easily when you can get a false passage. So we have a normal size tip on one side and a small tip on the one side, so that if you face too much resistance, you can actually go and use the smaller tip. The next thing was using the measure app, because you have to tilt the microscope to a particular angle, and not just for the sake of accuracy, but it really works in the terms of ease. If you have a measured angle and then you put a mark on the microscope exactly at that point. Okay, the mark is not seen here in the video, but if you put a mark exactly alignment, then you can, anyone, even the technician, can just rotate and tilt the microscope to that angle, and then you can do it hands-free. The other thing was when I was starting off, was the problem with bleeds. Now you can have bleeds anytime in GAT. When you are making the goniotomy after phaco or before phaco, when you are passing the suture, when you are ripping the suture, and when you are starting, you take time. you take time, and the more time you spend inside the eye, more will be the bleed that you get. So it was coming in the way of me learning this procedure. So the normal thought process was to go inject viscoelastic, wash off the thing, but that was again taking a lot more time, and the nurses were not happy to go to the store again, get another bottle of Orogel. The store people were not happy, and I had to sign a paper on why I'm asking for 4 Orogels for a single GAT, which should take 5 minutes to finish. So I thought this is enough. And my old friend from SICS days, the ACM, came into picture. If you have a bleed, use an anterior chamber maintainer. If the moment you put an anterior chamber and you aspirate whatever blood is in the anterior chamber, you will not have any blood interfering with your view during the entire surgery. And once you clear it, you will have a blood-free experience till the end of surgery. But remember that it is because that the ACM is continuously washing off the blood. It's not because there is no bleeding happening. So at the end of the surgery, you have to inject viscoelastic if you use an anterior chamber maintainer, and leave, as Dr. Ganesh said, 35 to 40% of Orogel. Also very important is that you stick to one viscoelastic. So we have different packages in our institute. In one package, we get only HPMC. There is another package where we get Orogel, another package where we get Helon, another package where you have Viscoat right there. And it was becoming difficult because I found out that in premium packages, I was getting very high IOPs on day one. That was because the amount of Orogel that you have to leave is different from the amount of Helon that you have to leave. So stick to one thing, or with time you can titrate the amount of viscoelastic that you have to leave. I stick to just one thing for all surgeries when I do GAT. You just need, I just use Orogel and I leave the amount of viscoelastic that would normally be beyond a rhexis margin. So imagine a rhexis in the central axis, and whatever is supposed to be the edge of the rhexis, leave all viscoelastic beyond it. Another interesting thing that we tried successfully was, because I go to rural centers also at my institute, and there you don't have microscopes that you can tilt. So you were trying to see how can we do this there, because a big problem in those centers is not there. If I do a trabeculectomy, everyone who has done a trab will know, everyone who has a child will know that the way you can take care of your own child, nobody else will do it. The way you can take care of your trabeculectomy, massaging, releasing the suture, teaching the patient how to massage, increasing, decreasing steroids, giving 5-FE injections, no one else will do it. So that is very difficult. So GAT gives you liberty from that fact, that you don't need to do all these interventions in the post-operative period. You cannot also do. So there's no option of doing it, and that's a freedom from responsibility. So in order to do that, we were thinking of something, and this is what we came up with. So we have a view here. You see this, look at this view. This kind of view, you see almost 120 degrees of the angle here. And the detail at which you can see this is amazing. Can you imagine what gonioscope is being used? It's not a gonioscope. It's a nasal endoscope that we are using outside the eye. And this is amazing, because this was difficult to do because there was one person who had to hold the endoscope. So I had Javed Ali, our wonderful oculoplasty surgeon, who was doing it for me. And this is the kind of view that you can get from the endoscope. And this gives you freedom from the tilting of the microscope. Even if you don't have a microscope that has the ability to tilt, you can still do this, and it saves you from a lot of things. You don't have to sit so far away from the microscope. You don't need the microscope at all. You're seeing it on a screen. So imagine the change that a retina surgeon has had because of Ingenuity, when they had to put all those inverters and biomes and all that, and they're looking straight onto a screen and doing this. So this can give you a lot of independence, and this is what was happening from the microscope end at the same time. So that is what the microscope is seeing, and this is what the endoscope screen is showing. So this is something that can give you independence from tilting, save your neck, because it's very easy to have a false posture when you're sitting so much far away and trying to reach for the eye. The view is great, and the reach that you can have with this is amazing, though the instrument is expensive. Thank you so much. And because we have time in hand, and there was this initial plan to actually circulate a form amongst us, and we will leave 10 minutes for you, sir, right? We have some time in hand, and I just wanted to look at the differences in the practice that we have. And this is the survey that we have, and there's some very interesting things that came up. Traditionally, angle closure is supposed to be a contraindication for GAT, right? But I believe most of us are doing GAT for angle closures. So, Dr. Ganesh, what kind of angle closures would you not do GAT for? Do you have a hand mic here?
I would stick to PACGs in which I can see the angle. There are some PACGs you can still see the angle. They're not zippered and closed. So those are the eyes I would go for.
So even if there are small goniosyne,
Yeah.
and you can see the angle and you have
Definitely.
space enough for goniotomy, you will still go ahead.
I would still go ahead, and sometimes you could indent and see. And if I see that more than 50% is getting opened up, I would give it a shot. It shouldn't be a zippered angle. That's one. Like the creeping angle closure ones which we used to see, they are definite. I wouldn't attempt that.
Great, and GAT works wonderfully well for them. I have 11 patients with 6 months follow-up, angle closures, all of them are working.
Working, the only caveat I would say is they will have qualified success if you have a very strict criteria of less than 15 compared to POAGs. And they sort of, in our series, they have come up to pressures of 18. We are not treating them, but you don't get the low IOPs in which you can get with POAGs. Or
Correct.
pseudo exposition. Pseudo exposition does fantastic well.
Absolutely.
Pseudo exposition with angle closure also does pretty well if you do it with cataract. But you'll get qualified success. You may not get complete success with the low IOP thresholds.
Great. And one thing that I realized is
But on the same hand, they don't have to be on medication. You can
they don't have to be. They are medication free most of the
You
time.
won't get low
Can
IOP.
we have another hand mic, please, for the expert panel? So you can do GAT under topical also, until unless you go behind the ciliary body and you are in the suprachoroidal space, you will not be causing pain. So because I believe the local anesthesia and the injection and massage that you have to give after the procedure is really responsible for the vision loss that you face in TRABs and AGVs and even GAT. So most of the patients who can look at a light, we are doing topical now, and it's possible and very easy to do it. This we have already discussed. And Dr. Ganesh, the 26 gauge that you use is the normal 26 gauge won't reach the angle, right? So where do you source this from?
We have the normal gauge does reach the angle. Why do you say it doesn't reach the angle?
No, because the one that we have, it doesn't.
No. We use the one which we give subcongenital injection if you want to.
Okay.
It goes across. It goes across, and I use that. We
Okay.
get it's a half-inch.
Hmm.
Yeah.
Which
the-
company is that needle
we
from?
get brown. Yeah, 26 gauge. Dispoman only. Honor Dispoman. Yeah. Brown
Okay.
cover. It goes very comfortably. I stopped using MVR because getting everything from the retina department is very difficult. So I try to have everything within. In fact, sorry, I didn't show the video with the SICS with the.
SICS with, yeah.
SICS was one. The other one was using microforceps. It didn't come up, but you could use a microforceps. So we abandoned taking anything from retina now. Be self-sufficient as much as possible.
Yeah, and the retina department, they use the disposable Grishaber forceps. You have a metallic titanium version also, which is a little more expensive, but that will last years for you. So we have shifted to that. We are also cutting off from the retina department till you have a nucleus drop. The other interesting thing is the sequence of doing phaco and GAT when you are doing a combined procedure. Dr. Swati, what do you do first, and why that choice?
So first I used to do cataract first because I wanted time for GAT. But then what used to happen that my wound, the phaco wound used to take away all my viscoelastic away. And again I had to fill my anterior chamber. And suppose if I have a hard cataract and I'll have SK at the tunnel, so half of my cornea will be gone in that, and I'll be struggling to see the angle. You can see, but it will be a little difficult. If you have a virgin cornea which is totally clear, you can have NFAS view very nicely. So, and if God forbid you have a nucleus drop, so your chance to do a GAT is gone. And then you struggle with the placing a IOL itself. So better to do one surgery, complete the glaucoma part, go to the the cataract part. That is why I shifted first to now GAT first and then phaco. I initially used to do SICS with GAT also. So that also there also I realized, because in SICS your side port has to be made. Then your side port for the GAT has to be made. So I used to feel, okay, let my one side port take care of everything. But that is not the case. So you have to meticulously plan if you are doing an SICS GAT, where your side port will land up and where your side port for the suture should be. So you should not make so many entries into the cornea just because you want to achieve something. We have to be still safe and give good results to the patient. So I would say first do a GAT, then go with the cataract surgery.
Great. Dr. Mahesh, you have something to add here?
Even before doing GAT, I just do the Rexis so that I don't injure the ALC. Just do the Rexis, then do the GAT. And that advantage that gives that after you place your IOL, you don't have to wash your visco out at the end of your cataract surgery, which will act like your 25% or 30% viscofill that you need to leave behind.
Right. Dr. Ganesh, you do phaco first, right?
I do phaco first. I do finish the phaco first and then do the GAT.
Right. Because the global thought and majority thought seems to be, or slightly in majority seems to be, doing GAT first. But here we are divided. I also do phaco first. Why don't you do GAT first?
Maybe because now we have started operating, angle closures slightly. So that's one tendency. That could be the reason. So you just get away with the phaco part of it and then concentrate more on the GAT part of it.
Yeah, the view is better. The other thing is that I had temporarily shifted to GAT first, but then I came back because there was one patient where I had a bleed, massive bleed, and the entire phaco became very troublesome. So when you have that, if and when, that's rare that the angle keeps bleeding, but then I did 4 or 5 phaco GATs with GAT first, and then I shifted to phaco first that way. I'll just end up with
Siddharth, one more thing. After phaco, there is blood in Schlemm's canal invariably. So that used to bleed. So I think it's surgeon dependent. Whichever you feel confident, you can do.
There's no right way or wrong way about it.
At least phaco gets finished fast. Then you can more relaxed. You can do your GAT part. One more thing, angle become deeper.
Sir.
Once you do a phaco, view is better and more confident. You don't need to bother about.
Right. The other difference is the kind of steroids that we use and the duration that we give steroids for. Mahesh, what your preference would be in these patients?
I give prednisolone first week 6 times. Prednisolone 6 times with antibiotics, and after 1 week, based on the hyphema that is remaining, mostly shift over to lotipred, or even sometimes now off late shifted to NSAIDs.
Okay. I'll just this last point. We have some time in hand. Sir, you can start setting up your thing. We will just talk here.
So in our center, we follow the same IOL post-op regime, 42 days. And unless we have a hyphema, then we can give 2 days intensive steroids like we do for trap. But mostly we follow 42 days regimens, 7 days. No sir. We do get steroid response, but after that, so then I shift to NSAIDs. We get sir, and that steroid response is very rapid, and but normally we get after 4 weeks steroid. But here in GAT, we get after 2 weeks also we can get. Sometimes I blame my orogel living inside for that. Sometimes I blame dexamethasone for that. But yes.
Yes. So I don't. I use steroid 4 times a day for 10 days. Then I stop it. I use NSAID for 30 days, 3 times a day, and antibiotic 4 times a day for 30 days. That's all. No steroid after 10 days. All the patients which I showed, there's no steroid going in after 10 days. 10 days. Because what exactly, why my philosophy changed this, I used to pump in a lot of steroids. Then I found steroid response because I feel that outer wall also reacts to steroid response. So remove the inner wall, so that whole thing is gone. And the other thing is, when you give, you don't, and you're taken the resistance for inflammation to be retained in the eye. The only way inflammation can go is through the trabecular meshwork. So you remove the whole thing. So you're not treating inflammation. You're treating hyphema. Hyphema doesn't require steroids, number one. Number two, hyphema doesn't remain there also if you put orogel. So there's no inflammation in the eye. So you don't need steroids at all. So use 4 times a day for 10 days and stop. What about you?
The same thing. I use Miticom, Vigadex, or Maxim D, a combination for all my cataracts and GATs, phaco GATs. I use it for 10 days and then stop it. So
one patient I started now recently after 3 weeks, she came with allergy to NSAID. So even now NSAID, I think I'll stop in very quickly. They don't. Eye is white and quiet. There's no inflammations. They see 6/6. You have to give glasses in 10 days. They do as good as phaco, if not better.
Any case where you needed to convert to trap, you have said like we have the
Patients, especially this happens in pediatric eyes. This happens in pediatric eyes and early learning. If you test at the wrong age, then yes, do not like feature the sign. You're not looking into it because when we went back to the literature, I saw it's a type of complication, and that complication is there in juvenile sarcomas. So why did I operate this case? So that patient had undergone a trap. Most of these pilocarpine and I don't use pilocarpine. No pilocarpine. No cycle. No pilo, no cycle.
for a normal thing versus a Miticom for C2 with NSAIDs for C2. Thank you so much. Thank you, Dr. Kavi. I'm learning a lot from you and keep learning. Mahesh is the one, we attended a webinar together and got inspired by people from the US who were doing GAT, and he is the one who started GAT at LVTI. He forced us into doing it. Thank you, Mahesh.
Later. Thank you. Very excellent discussions on GAT. Quite typical discussion now about the neovascular glaucoma, my experience. I am an invited guest faculty from Bangladesh, and I wanted to share my experience on neovascular glaucoma. I don't have any financial interest doing this presentation. I want to start with a case presentation. A 50 years old male, diabetic for the 15 years, came at our institution with sudden painful reduction of vision with watering and foreign body sensation. Patient was diabetic for the long time. Patient vision was hand movement. There is no improvement with the pinhole. And this is the condition of the patient, the huge bullous keratopathy with 46 intraocular pressure. This is the more magnified view. I started brinzolamide, brimonidine tartrate, timolol, and I started with carbonic anhydrase inhibitor. And also I admit the patient with, I have given 20% mannitol for the preparation for the operation. And after mannitol, intraocular pressure was 30. The just cornea is almost clear in the day after giving the mannitol. And this is the condition of the patient. In the second day, the again rebound raise of intraocular pressure of 45 millimeter of mercury. And what are the challenges in this case is rebound raised intraocular pressure, endothelial decompensation, failure of conventional trabeculectomy. So I plan to do the Ahmed glaucoma valve implantation. In this case, the quality of video is not very good. So the tube is going to be fixed. I used to use the self-sclera flap, trimming of the tube. Perfect tube placement is very much important in this case, as the corneal endothelial is almost decompensated. So this is the post-operative follow-up. You can see there is no bullous keratopathy and tube in the anterior chamber. And after 7 days, intraocular pressure was 15 millimeter of mercury, and the vision was improved. And this is the picture of the 7th post-operative day. So in the visual acuity was hand movement, and after 1 month it is 636. Intraocular pressure is 46 millimeter of mercury. After Ahmed valve implantation, it was 15 millimeter of mercury. There is a huge improvement of the vision. So angle neovascularization, in my experience in my country, is the two types of neovascular glaucoma. One is open angle glaucoma, one is angle closure glaucoma. Angle closure glaucoma used to develop due to fibrovascular contraction later on. And in that case, when there is an angle closure neovascular glaucoma, in that case the postoperative outcome is really challenging. And in my country, the commonest cause of neovascular glaucoma is diabetes plus CKD, CRVO, CRAO, vasculitis, sickle cell anemia, and Coats disease. And this is the pathogenesis like hypoxia, VEGF induction, endothelial proliferation, ANG2 induction that may cause the angiogenesis. So the management protocol is to use the mydriatic and cycloplegic anti-glaucoma, but no prostaglandin or pilocarpine, steroid eye drop for a little period, topical NSAID, and anti-vascular endothelial growth factor, which is given by our retina specialist. And surgery used to do trabeculectomy with MMC or trabeculectomy with collagen implantation if it is an open angle. GDD, glaucoma device, glaucoma drainage device, valved or non-valved. Used to use the Ahmed valve and Barvelt. Adi is not available, so much available in our country, and sometimes cyclophotocoagulation. Transscleral cyclophotocoagulation has some role. I have some experience with doing this with cyclodiode. If patient has a very much painful blind eye with almost NPL vision. Endocyclophotocoagulation is also going on there. So I want to show you a video of 20 years old by poor socioeconomical background. Cataract operation was done. Secondary glaucoma, patient had a secondary glaucoma after cataract operation, and ultimately patient developed neovascular glaucoma later on. And patient underwent trabeculectomy. Ultimately it was failed. IOP 1 not control with highest medication, and plan for non-valve tube implant. It's a very short video. Actually, tube is going to be inserted. So usually I used to use the tutoplast for covering the tube. So my take-home message is, no doubt, glaucoma Jennings device implant surgery is a good option for refractory glaucoma, especially in the neovascular glaucoma, and it reduces patient mental and financial burden and improves social life. Thank you. Thank you for patient hearing.
Sir, do you do diode CPC in some cases, or to reduce the pressure, or you
No, in
directly-
some cases where the patient has a like hand movement vision with some PR in the one quadrant, in that case, and patient has a severe intraocular pressure with painful eye, and it looks that even Ahmed glaucoma valve is not very much suitable, or any valve. Even the most important thing is where the patient cannot afford the Ahmed or Bearwell, because we don't have the Adi in our country still. We have Bearwell and Ahmed.
Okay, and sir, for eyes with visual potential, you will directly go for GDD.
Yes, no, directly go for GDT.
Sir, any indications where we will use AGV and where you will use Barwell?
No, actually, but in my country, we used to use Ahmed glaucoma implant more, because Barwell is very much expensive, and I don't have any selection where I will have the Barwell, because Adi is also prototype for Barwell. So but in case of very high intraocular pressure, it is a 50 or 60. In that case, I preferably use Ahmed valve implant, because in the Barwell implant we have to cross. Yes, hypertensive phase was there, and patient has an advanced glaucoma. In that case, I used to use the Ahmed implant to avoid the wipeout.
Okay.
Thank you.
Sir.